afternoon, dear students. As I said in the very first discussion of the radiology of urinary system, that there are so many conditions or diseases which involve or can involve the urinary system. So we can divide this discussion into three parts. And so far we have discussed the part 1 and part 2, and today we are going to discuss all these conditions in part 3 of the radiology of urinary system. Now the first slide you can see is a condition in which the trauma may involve the urinary bladder, lower abdominal injury in the roadside traffic accidents. Here you can see the bladder rupture with intraperitoneal spill of the contrast. The next slide. In this cystogram has been performed, an X-ray of the pelvis obtained. There you can see the extravasation of the contrast into the peritoneal cavity from the anterior surface of the urinary bladder, which shows a rupture or some injury. In the previous section, part 2, we did see the herniation of the ureter, and now in this condition we can see the herniated bladder, which is going through a small opening down into the interior part of the thigh. The contrast filled bladder, you can see white shadow in your screen. Now pear shaped bladder. This most commonly occurs where there is chronic cystitis and reduced capacity of the urinary bladder. So the picture in IVP or cystourethrogram is the pear-shaped bladder. Pelvic hematoma. Here you can see the high density bladder in the center of the pelvis, and this is surrounded by radiolucent area which is all filled with the hematoma, and is just compressing the bladder from all the ways. Pelvic Lipomatosis. The very dark shadow is because of the negative picture obtained. There is Foley's catheter placed, and some urine is present in the urinary bladder, which is all squeezed by the presence of excessive pelvic fat. The condition called pelvic lipomatosis. Now this is fibromuscular dysplasia, which most commonly involves the renal artery. Here you can see the beaded appearance of the renal artery. However, the flow to the kidney is still intact, but later on such conditions may give rise to the hypertension. Another case of trauma, it may be iatrogenic, maybe road traffic accident, where you can see the disruption of the right renal artery depicted by a small arrow. And on the right side of your screen, the repair has been done, and you can see some of the contrast or some of the flow is going into the right kidney after the repair of the right renal artery. On the left side, on the left, the left kidney shows normal contrast excretion. Cortical necrosis. You can see the difference between the two kidneys, the right and the left. The left kidney is contracted, and this is showing the cortical necrosis, reduction in the thickness of the cortex. Bladder masses. This is You can see the filling defect on the right side of the urinary bladder. This is all filled with the contrast, but the filling defect with ill-defined border is actually a mass which is filling the right side of the urinary bladder. This is ultrasound picture of carcinoma of the bladder. Here you can see a broad-based mass on the right lateral wall of the urinary bladder. Another case, bladder mass, which is present in the region of the trigone and involving the ureter, resulting in the proximal hydronephrosis. Carcinoma bladder. Urine jet is coming from the right vesico-ureteric junction adjacent to the bladder tumor. Now sometimes there are pseudotumors which result from the inflammatory condition of urinary bladder. They very much look like the bladder carcinoma, but biopsy and cystoscopy is performed to clinch the diagnosis. Multicentric urothelial tumors. Here you can see a ribbon-shaped ureter, the bladder filling defect. The right kidney shows multiple filling defects. Only few calyceal systems are, few calyces are outlined, filled with contrast, and there is distortion of the kidney because of the presence of the multicentric urothelial tumor. Now the bladder tumor may occur in the adjacent diverticula or diverticulum due to the chronic irritation, and here you can see a tumor which is involving the diverticulum depicted by an arrow. A little bit of the contrast is present. This is a CT image of the pelvis, and you can see the small amount of contrast which is present at the base of the urinary bladder. Now this is the extensive look of the urinary bladder tumor, which has gone beyond the urinary bladder wall. MRI is the study of choice to see the extravesical extension of the disease or grading of the mass. You can see the curved arrow and the straight arrows indicate that there is invasion of the muscular wall, and on the left of the picture this has gone beyond into the pelvic structures as well. This is focal wall thickening. Again, it's very difficult to differentiate it from bladder carcinoma, but cystoscopy, history, and lab investigation can tell us about the malignancy or the chronic wall thickening due to the focal cystitis or some other likewise conditions. Now the whole wall of the urinary bladder is diffusely involved by a neoplastic mass. Here you can see the contracted bladder, very much thick walls, urine present in a small quantity in the center of the urine. This is again the CT picture, axial view at the level of the hip joints. Extensive bladder mass, as you can see, it's involving the urinary bladder on the right side with urinary bladder wall, muscular wall, and extra vesical structures, fat stranding, and other pelvic muscles and tissues depicted by the straight arrows. CT picture at hip joint level. Urethral stones we have seen very much commonly in the previous study, but if you can look at the lower segment of this image with the long arrow, you can see the stone which is present in the urethra. The small arrow indicates the presence of the stone in the right kidney, but urethral stones are not very common, but still they are when they are passing through from the urinary bladder. At their exit, they sometimes stuck in the urethra, proximal urethra or distal urethra, so they can be seen on plain X-rays. Now there is extensive ureteric neoplasm. Here you can see the whole of the renal pelvis on the right side is filled with the soft tissue mass, cortex still intact and showing contrast enhancement. On the left side, the kidney is very much normal. The tumor on the right side is extending into the ureter as well, so resulting in hydronephrosis as well. Cystocele. We have seen this case in the previous sections. Now, urethral injuries, not very uncommon condition. This again can be iatrogenic or maybe a result of the road traffic accidents. These are different types. Now in this picture you can see the type 1 injury depicted by the arrow. There is narrowing at that. This is bulbous urethra, and you can see the arrow over here, and dilated proximal urethra, which indicates the obstruction. This is type 2 injury, and the big white arrow shows extravasation of the contrast. This is ascending urethrogram, but urine or contrast has still managed to go retrogradely into the urinary bladder. Stricture urethra. We come across this condition very commonly, resulting from the iatrogenic, post-iatrogenic trauma, road traffic accidents, or chronic inflammatory conditions, resulting in strictures at various levels. As you can see the dilated penile urethra and strictures at bulbar and prostatic urethra level. Contrast has managed to go retrogradely to the urinary bladder. Another case of stricture urethra. This is a tight stricture urethra, but still the contrast has forcefully gone into the urinary bladder retrogradely. Urethral polyp, not a very common condition, but we have to differentiate this from the urethral stones because the filling defect. So in the presence of the stone, the filling defect very much look like these urethral polyps, but ultrasound is the study which can depict or which can differentiate between the presence of the polyp and the stone. This is a large urethral stone. You can see the urethra has made two channels, the one with small arrows, and the large arrow shows a large filling defect into the other false urethra where a stone is present. Prostate. Now this is ultrasound picture. This is called transrectal sonography. Here you can see the reverse picture. This is prostate in the center. Now in inflammatory condition of the prostate, which is called prostatitis, there is increased vascularity. You can see when the Doppler is put on, there is moderate vascularity, which indicates some inflammatory process going in the prostate, which is called the prostatitis. This is prostatitis with benign prostatic hypertrophy. Again, moderate vascularity. Prostatic abscess. Here you can see a hypoechoic area which indicates there is some collection of pus or inflammatory material, and this lead to the retention of the urine because of the increased size of the prostate, and there is resulting retention, but this is a case of the prostatic abscess. Enlarged prostate IVP performed. Here you can see the large filling defect at the base of the urinary bladder. Proximal distal ureters are outlined, and urinary bladder show a filling defect from the base, and this is a large prostate. Ultrasound picture of the benign prostatic hypertrophy. In this case, there is enlarged median lobe. Urinary bladder is filled, showing wall thickening, resulting in chronic hypertrophy of the wall because of the presence of the benign prostatic hypertrophy. Another case, this is transrectal ultrasonography. The study of choice to look for the prostate and prostatic diseases is transrectal ultrasound. Now, prostatic neoplasm. In the left of the screen, you can see a small rounded hypoechoic area which is significantly different from the rest of the normal prostatic echo pattern. This is a small prostatic neoplasm. Now we are coming to the renal transplant. Renal transplant is mostly done in the condition where there is end renal disease, end stage renal disease. So the transplant kidney is mostly placed in the right iliac fossa, where the union of the renal vessels is performed with the iliac vessels. Here you can see the IVP performed in the transplant kidney. Here you can see the renal system and the right iliac bone. Urinary bladder is also outlined, and there is no indication of, there is no contrast excretion through the native kidneys. Renal transplant kidney, ultrasound picture. Another picture of the renal transplant kidney when the power Doppler is on, and you can see the vascular distribution. Yet another picture, power Doppler is on, and you can see all the vessels comfortably supplying the renal parenchyma. For the assessment of the transplant kidney function or the vascularity, the renal Doppler is performed, and the resistive index should be less than 0.7, and in this case this is 0.71, still within normal limits. This is again a renal Doppler in the renal transplant kidney. Resistive index is 0.63, normal. Now this is the arteriogram, conventional arteriogram. Here you can see the contrast inside the common iliac artery, and the union of this with the transplant kidney shows a stenosis at the transplant site depicted by a black arrow. Now, apart from the renal artery stenosis, renal vein thrombosis may occur in the transplant kidney. On the left of your screen, this is a normal Doppler, and on the right side where there is renal vein thrombosis, where you can see the signal which is baseline, which is going below the reverse artery flow. This is indication of the renal vein thrombosis. So these are the non-invasive investigation where you can see whether the renal transplant kidney is functioning well, or the transplant or the union of the vessels is perfect, or there is element of stenosis, stricture or thrombosis of the transplant vessels. Again, another picture of ultrasound picture of the transplant kidney, not looking very good because the corticomedullary distinction is not very good. Renal parenchymal disease. It has different grade 1, 2 and 3. In the grade 2 or 1 or 2, you can still see the differentiation between the cortex and the medulla. But when there is a grade 3 condition, then there is totally loss of CMD, and the kidney is very much bright, echogenic and sometimes contracted. So that's called poor CMD or end stage renal disease. Now this is the assignment for today's discussion. Which side renal cell carcinoma is prone to enter into the inferior vena cava? Here we come into the end of the discussion of the radiology of the renal system. We have covered this in 3 parts, part 1, part 2 and part 3. You have all these discussion, and you can revisit all these and you can enjoy this. Thank you very much.